some specific tissues like preosteum, arterial walls, joint surfaces, falx and tentorium. I talked about this before, right? So that's why any damage to these tissues is very painful. And there are other tissues that don't have enough of these pain receptors, so damage in these tissues may not be painful, like lungs and liver, the brain itself, right? And remember that Pacinian corpuscles were sensitive to pressure. Pressure is a type of mechanical energy, right? You should remember that if we apply pressure to the Pacinian corpuscle, some mechanosensitive sodium channels were opened, then sodium went into the cell, that caused receptor potential, and that receptor potential caused action potential in the first node of Rankin. That was the mechanism for activation of a Pacinian corpuscle, right? But for pain receptors, we have other type of ion channels. We have several categories. You can see that we have 4 different or 5 different types of please turn off your cell phones. We have different categories of ion channels. Transient receptor potential channel. So this is the name of a channel, right? This one. Transient receptor potential. This is a channel. So we have TRPV1, TRPA1, and also other types. They are activated by heat, acids, chemicals, right? We have the second class, which is called acid sensing ion channel. So this is the second category. The third one is cholinergic receptors. So they include P2X, P2T. They are activated by ATP. So damage to the tissue may cause rupture of the cells. ATP is released. It can bind these receptors on nociceptors and cause ionic current that cause receptor potential that is converted to action. So this is the mechanism, right? We have another class, tyrosine receptor kinase A. So in Pacinian corpuscle, we have only one type of mechanosensitive sodium channels that is sensitive to pressure. But in nociceptors, we may have several types of ion channels, right? Each of them is sensitive to a specific type of damage. For example, some of them are sensitive to cold, like this one. Others are sensitive to mechanical damage, like these two. We have other categories that are sensitive to acids and also to heat, right? So this type of damages cause opening of these channels. Maybe several types of ions enter the cell. They cause a change of potential, which is called receptor potential. Receptor potential is converted to action potential. Then action potential goes to the spinal cord, right? Through the nerves. So now, based on these channels, we may have 3 different types of nociceptors. Some of them are called mechanical. You may have thermal nociceptors or chemical nociceptors, right? Depending on the type of the damage that activates these channels. So if a mechanical damage activates a nociceptor, it's a mechanical nociceptor. Some other times, a thermal stimulation like hot or cold, right? Heat or cold may activate thermal nociceptors. Or maybe some chemicals like many chemical substances, right? Activate the nociceptor. So these are chemical nociceptors. They are sometimes called polymodal. These, right? Why? Because they are activated by chemicals and also by thermal and mechanical damages. So thermal nociceptors are only activated by extremes of temperatures, right? mechanical nociceptors are only activated by mechanical damage, but chemical nociceptors are activated by chemical substances and thermal and mechanical damages, right? So, some substances that activate these channels for these nociceptors include bradykinin, histamine, acids, serotonin, potassium, and proteolytic enzymes. Some other substances actually don't activate these nociceptors directly, but increase their sensitivities. For example, we have prostaglandins and substance P. They increase the sensitivity of nociceptors, chemical nociceptors, to other chemical stimulations, right? You should remember these. Okay. We have a fourth category of nociceptors called silent nociceptors. They are not activated by tissue damage, usually, right? But in some specific conditions, they are activated. For example, if we have inflammation, then these receptors are sensitized, and after that, they may respond to other type of stimulations, right? So in normal situation, they are not activated if we have damage. So they are present in the tissue, but they are not activated. But if you have inflammation, after some time, they are sensitized and they add to the sensation of pain that we have, right? Okay. So remember that we have two types of pains, right? Slow pain and fast pains, right? Physiology. Here we have fast sharp pain or slow chronic pain. And we have four different types of nociceptors, right? So thermal and mechanical nociceptors have A delta fibers, but polymodal and silent nociceptors have C fibers. So C fiber is unmyelinated, but A delta fibers are myelinated. So fast pain is transmitted through A delta fibers, but slow pain is transmitted through C fibers. So if we have damage to a specific area of the skin, at the same time, fast fibers and slow fibers are activated, right? So the fast fiber carries the signal very fast, so we feel pain soon. After a while, after some milliseconds, C fibers also transmit the signal, so we may have the second pain. So after the damage, we have two pains, the fast pain and the slow pain. And there is a small, actually, delay between these two. So this is called double pain. So after damage, we have double pain. The first part is transmitted through A delta fibers, but the second part is transmitted through C fibers. Which one is more? Which one is more severe? Yes, fast. Yeah, first. Second one is actually smaller, but it long lasting. Right? So, pain pathways. Remember that for somatic sensations, we have two pathways in the spinal cord, DCML system and anterolateral system. I talked about this before, right? So, pressure, touch, vibration, position are transmitted through DCML system, but sensations like pain, temperature, itch, tickle, sexual sensations are transmitted through anterolateral system. Another name is spinothalamic, right? So we have two spinothalamic pathways. So two parts of the spinothalamic pathways include neospinothalamic, paliospinothalamic. So neospinothalamic is the newer one. So we have them in higher level animals, like in humans. But paliospinothalamic tract is an older one. We have them only in lower level animals, right? So let's see the pathways here. So A delta fibers bring fast pain, right? C fibers bring slow pain. So they come to the spinal cord, but they end at different layers of the spinal cord. So let's see. A delta fibers enter layer 1 and activate fibers here. So the second order neuron originates from here, goes to the opposite side, enters the anterolateral pathway and goes up. Right? Here, the lateral part of the anterolateral pathway. But C fibers enter the spinal cord, and in layers 2 and 3, some of them activate neurons here that go to layer 5. From here, other neurons go to the opposite side in the anterolateral pathway and go up in the anterior part of the anterolateral pathway. So anterolateral pathway has two parts, lateral, ventral, right? The ventral part is called paliospinothalamic tract for transmission of slow pain. The lateral part is called neospinothalamic tract, which transmits fast pain. So in the anterolateral system, we have two tracts, lateral one, ventral. The lateral one is responsible for transmission of fast pain, but the ventral one is responsible for transmission of slow pain. Let's see the neurotransmitters here. So when A delta fibers come to the spinal cord, they release glutamate, right? But C fibers release glutamate and substance P. So you know that substance P is a neuropeptide. It has long action, right? So we have longer pain if substance P is released by C fibers, right? So it activates the receptors for a longer time, so the feeling of the pain will be more, right? So now let's see the termination point of these pathways. They go off and reach the brainstem. In the brainstem, we have actually divisions of these pathways. So the neospinothalamic pathway, which transmits fast pain, mainly goes to thalamus. Some of them end in reticular formation of the brainstem, right? So let's see. So the fast pain comes through lateral part of the anterolateral pathway, right? They come to the brainstem. Some of the fibers end here, a few of them, right? So a few of them terminate in the reticular here. But most of the fibers go to the thalamus. They end in the same nucleus that receives touch, pressure, and vibration. What was that nucleus? VPN, ventral posterior nucleus, right? Lateral part, ventral, and medial part. Remember that? Okay, they enter the ventrolateral, ventral posterior nucleus, right? And from here, they go to area S1, somatosensory area 1, which is also responsible for touch, pressure, and vibration, right? So, A delta fibers bring the signals to the spinal cord. They end in layer 1. They release glutamate, right? They activate the second order neuron, which goes to the opposite side, enters the anterolateral system, goes to the lateral side, then goes up. Most of the fibers that travel in this pathway end in thalamus, in ventral posterior nucleus. From here, they go to the cortex, area S1. Right? But some of the fibers enter reticular formation. Good. Now let's see paliospinothalamic tract, which brings slow pain from C fibers. Right? So they go up through the spinal cord, enter the brainstem. Most of the fibers terminate here. Only a few of them go to the thalamus. But when they go to the thalamus, they go to a different nucleus, not VPN. They usually go to intralaminar nuclei. So we have several nuclei in the lamina of the thalamus. We call them interlaminar nuclei, right? So let's see. 10 to 25% of the fibers in the pathway terminate in interlaminar nuclei. They include parafascicular, centromedian, and central-lateral nuclei. So we have 3 nuclei here, right, that receive sloping. So those fibers that go to the reticular formation go to medullary and pontine reticular formation, and from here they go to interlaminar thalamus. Some of them go to periaqueductal gray region in the midbrain. Some others go to the tectal area. So we have the spinal reticulum, spinal mesencephalic, spinal tectal tracts. All of them are part of the spinal thalamic tract ventral part, right? So we have 2 pathways for transmission of pain, one for fast pain, the other one for slow pain. Most of the fibers in neospinal thalamic tract go to thalamus, then from thalamus to cortex, but most of the fibers in the paliospinal thalamic tract go to the reticular formation in several areas. Reticular formation of medulla pons, that is called spinal reticular tract. Yeah, in periaqueductal gray region, part of the reticular formation, right? Spinal mesencephalic tract, tectal areas in the midbrain, spinal tectal tract. So, let's see what are the functions of these centers. So we have reticular formation, thalamus and cortex that receive pain signals, right? So if we remove the whole cortex, for example, in an animal, in a cat, if we remove the whole cortex and bother the animal, I mean, give painful stimulation, the animal reacts to this painful stimulation. So this means it can still sense the pain, right? So we can say that the cortex is not necessary for feeling pain. So lower part of the brain, like thalamus, like reticular formation, right, are enough for feeling the pain. But what is the function of the cortex? Yeah, for memory of the pain, for judgment about the quality of the pain, for speech. No, I'm talking about pain. I mean, what is the function of cortex in relation to pain, right? So, yeah, interpreting the quality of the pain, knowing that we have pain, right? Yeah, memorizing the pain quality. So these are the function of the cortex. So based on this, we can say that neospinal thalamic pathway is responsible for discriminative aspect of the pain. So you have 2 aspects for pain. So it's different from other sensations. If you have touch, right? So we only feel touch. So it's a type of sensation. But when we have pain, it's different. We have both sensation of the pain and the feeling of the pain that we don't like it, right? So it has an emotional part also. So it has 2 parts, a sensation part and an emotional part, right? So we can say that neospinal thalamic pathway is mainly responsible for discriminative or informative or sensitive aspect of the pain, but paliospinal thalamic pathway mainly mediates motivational or emotional aspect of the pain. Okay, so now we know the anatomy of the pain pathways. If we have a patient with severe pain that is not controlled by painkillers, sometimes we can have surgeries to relieve pain, right? So we know that the anterolateral system is located in the anterolateral quadrant of the spinal cord, right? Anterolateral quadrant. So If we cut the anterolateral quadrant, we can cut the pain fibers. Pain fibers in the spinal, right? So now imagine that we have a patient that has severe pain in the left leg because of a tumor. And we have used any medication, but they weren't helpful, right? So now we want to do a surgical operation. So we can cut anterolateral quadrant of the spinal cord on which side? On the right side. Good. Because fibers for pain come to the spinal cord and in the spinal gray matter, dorsal horn. Then other neurons go to the opposite side and go up. Right? So on any side of the spinal cord, we have fibers that carry pain from the opposite side. Right? So if we have pain in the left leg, then we should cut fibers on the right side. Right? So this is one type of surgical operation called chordotomy. Cord means spinal cord, tomy means cutting. Right? Chordotomy. Another type or another way for surgical operation is cauterization in the intraluminal nuclei. Cauterization means burning the tissue by electrical current. So you can have DC current, high voltage DC current, and burn the tissue, right? So surgeons can do this in thalamus in intraluminal nuclei, right? We know that intraluminal nuclei mainly are involved in slow chronic pain, right? Because they receive fibers from paleo-spinothalamic tract. So if we burn them, it means the patient can still feel sharp pain, but they cannot feel chronic and slow pain. And this is actually better, right? So cauterization is another way for interruption of pain pathways. So parallel to this pathway, we have another pathway that comes down through the brain and the spinal cord, and it has a reverse action related to the pain pathway. So we have an ascending pathway which is involved in pain sensation. We have another descending pathway which suppresses the pain feeling. Right? So we call that analgesia system. So let's see. It starts from periventricular nuclei of the hypothalamus. So neurons from here go to the PH, periaqueductal brain. So why we call this PAG? Because we have a tunnel here in the brain, so we call this aqueduct, right? So it's a connection between the third ventricle and fourth ventricle. So inside the ventricle we have CSF, right? CSF from the third ventricle can go through this aqueduct to the fourth ventricle. Around this tunnel, around this aqueduct, we have gray matter, right? That's why we call this periaqueductal gray matter, so PH. So the name of this area, right? So neurons from the thalamus go to this area. From here, other neurons go to nucleus radius magnus in the pons, right? From here, neurons go to the spinal cord, go down, and reach spinal segments, right? So in the spinal cord, they activate some interneurons that release enkephalin. So remember this name. Enkephalin is a neurotransmitter, is a neuropeptide. It's like morphine, right? So it binds to opioid receptors and actually block the substance, the synapse between the pain neuron, pain afferent neuron, and pain relay neuron. So imagine that this one is a C fiber that brings pain signal to the spinal cord, activate this neuron, this one goes to the opposite side and enter the anterolateral system. You know this, right? So we have a synapse here. So it's here, right? So between A delta fiber and relay neuron, or C fiber and the relay neuron. So we have a synapse here. Okay? This synapse is blocked by enkephalin that is released by this interneuron. So what happens if this synapse is blocked? Pain signal comes from the skin to the spinal cord, but it cannot go up. It remains here, right? So we have a descending pathway from the brain that goes step by step down, reaches here, activate interneurons release enkephalin, enkephalin blocks the synapse between the C fibers and the relay neuron, right? So this way we can block pain. So how does this system work? I mean, why we feel pain if we have this pathway? If it blocks pain, so why we feel pain? Okay, because this system is not always active. It's only activated when we have high level of emotional state. Because hypothalamus is part of the brain responsible for emotions. So when we are excited, for example, right? So this system is activated and blocks pain. So that's why if a football player, for example, is injured during the game, right, they don't usually feel so much pain because they are excited. There are a lot of people there, right? Yeah, emotional level is very high. So hypothalamus is very active and it can activate this descending pathway. So feeling of the pain is less than normal situation, right? But if you take this player out of this field, then they start feeling severe pain because this system is deactivated. Then pain signals can go off and cause pain.
That's why we feel more pain at night.
Yeah, maybe at night.
Because you have nothing to be busy.
Yeah, maybe, but actually there are other factors that cause maybe feeling of the pain. Maybe circadian rhythm is also involved. Circadian rhythm means oscillations that happen in physiological parameters, and this oscillation depends on time. For example, after uh, after sleeping, right? So we have release of growth hormone, right? So we have release of growth hormone only in the middle of the night, in some stages of the sleep, right? So, but not during the day. Yeah, but for example, for cortisol, we have another circadian rhythm that is only released just before waking up, right? So this is circadian rhythm. Maybe for pain, we have also circadian rhythm, right? So during the night, we feel more pain. During the day, we feel less pain. Okay. So let's ignore this one. So write somewhere that we ignored slide number 14, and I will talk about this one, okay? Visceral pain. So far, we talked about somatic pains, pain that starts from the skin or from bones, somatic part of the body, right? We are aware of that. We know the localization, right? But we have also pain from internal organs, like the stomach, the intestine, right? The heart. So these are internal organs. So we call them visceral organs. So maybe damage happens here and we feel visceral pain. But the type of stimulation of nociceptors in these areas is different from stimulation that happens in somatic areas, right? In somatic areas, even a small injury causes pain. But here, sharp and small injuries don't usually cause pain in internal organs, right? for pain, for having pain in internal organs, we have widespread stimulation, not very sharp stimulation. So, for example, you may cut the stomach without any pain. Why? Because nociceptors are very sparse here. They are far from each other. So if you have a sharp injury, maybe only a few of them are activated, not more, right? So we don't usually feel pain. But if we have inflammation here, inflammation is a type of widespread injury. Then a lot of these nociceptors are activated, and the patient feels pain. So for feeling pain in internal organs, we need widespread stimulation, right? So this may happen after ischemia. Example is the heart attack. So if you have myocardial infarction because of the ischemia, a large region of the heart is affected, then a lot of nociceptors are activated, then the patient feels very strong and severe pain, right? Chemical stimulation, like peptic ulcer, right? Because of the release of high concentrations of acid in the stomach. So nociceptors are activated, the patient feels pain, right? Spasm. So contraction, prolonged contraction of the tissue without relaxation, right? This causes metabolic injury to nociceptors, then the patient feels pain. Another type of widespread stimulation is over distension. So imagine that you have a piece of intestine, right? We have a block here, materials want to go this way, but we have a block here. So this intestine before this block is over distension. This over distension activates nociceptors, the patient feels pain again, right? And last one is stretching the connective tissues. Connective tissues that cover the internal organs. So you know that we have peritoneum that covers the stomach, intestine. We have pericardium that covers the heart. We have pleura, which covers the lung. We have also some layers that cover the brain, right? Like dura mater, cranial mater, arachnoid. So if we have a stretch of these connective tissues, then the patient feels severe pain because those receptors are activated, right? So type of stimulations that cause visceral pain include ischemia, chemical stimulation, spasm, over distension, and stretching of the connective tissue. But I told you before at the beginning of this session, other tissues like the liver, the lungs, we don't have nociceptors, so these type of stimulations in these tissues are not painful. Right? So another feature of pain is referred pain. This only happens for visceral pain. So if we have pain in an internal organ, usually we feel it in an area in the surface of the body, right? So the patient may have heart pain, but the pain is referred to the left arm or the left side of the neck, right? So the origin of the damage or the origin of the pain is from the heart, but the feeling of the pain is in the heart. So we call this referred pain, right? Or maybe we have other type of referred pains. For example, esophagus is here. Damage to the esophagus causes pain in this region, right, in the chest. So we may have also, for example, let's say stomach pain that is referred to the skin in this region, right? So this is referred pain. instead of feeling the pain inside the body, we feel it in the surface, right? So refer to it. This only happens for visceral pain, not for somatic pain, right? So what is the mechanism of referred pain? So remember from our second topic that we had convergent circuits. Convergent circuits was like this. We have two neurons that come to one single neuron, right? So we may have convergence from several sources, right? The same happens here. So let's see. So we have some pain neurons in the spinal cord that carry pain signals to the brain, right? But these fibers or these neurons may receive pain signals from two sources, from the skin and from the visceral organ. So pain signals both from the skin, somatic pain, and from the internal organ, visceral pain. Both of them converge on the same neuron. So the same neuron is responsible for transmission of somatic pain and visceral pain. So now imagine that you have somatic pain. Okay. C fibers, A delta fibers are activated from the skin. They go to this neuron. The neuron carries the signal to the brain. We feel pain. We know that the origin of the pain is from the skin. Right? Now, ignore this. Think about this. We have visceral pain from an internal organ. It comes to the same neuron. The same neuron goes up and reaches the brain. We feel pain. But the brain interprets the pain as if it's coming from the skin, not from the internal organ. Why? Because usually we are not aware of our internal organs. We cannot feel our stomach, or we don't have any images, any internal images of our heart or our intestine. They are inside the body and we are not aware of it. So pain from these organs is not also reaches consciousness. Okay? We know that we have pain, but we think that the pain is originated from the skin. Right? So this is a convergent circuit. That is the mechanism for referred pain. The same also is shown here. Pain from the kidney and pain from somatic structures go to the same neuron, and the neuron goes up and reaches the brain, and we feel pain. So when we feel pain, we think that it's coming from this one, not from this one. Right? So referred pain. So remember that peritoneum, precardium, and pleuron have two layers, right? A visceral layer and a parietal layer. So if we have damage to these tissues, this damage may spread to the parietal layer, right? And you should know that these layers have different innervations. Visceral layer is innervated by autonomic nervous system, sympathetic and parasympathetic nervous system, right? But parietal layer is innervated by somatic nerves, somatic spinal nerves. So two different systems innervate these layers. So we may have injury here. Injury is present both in visceral layer and parietal layer. So two different systems carry this pain signal to the brain. Autonomic system and somatic system. So at the same time that we have visceral pain and it's referred to an area in the surface, we have also parietal pain, right? So the patient may have two different pains with two different qualities. So let's see an example. So appendicitis, right? So because of an inflamed appendix. So it's here, part of the colon. Imagine that you have inflammation here, and it's covered by peritoneum. So peritoneum here has two layers, visceral layer and parietal layer. The parietal one is innervated by somatic nerves that go to lumbar one segment, right? But the visceral one is innervated by sympathetic nervous system that goes to thoracic 10 level, thoracic 10 segment, right? So two different nerves carry the signals to the spinal cord. One goes to lumbar one, the other one goes to T10, right? So the pain which is sensed here by this nerve is somatic. So it's sharp and highly localized, right? So the patient knows exactly that he or she has pain here in the right lower quadrant because the appendix is here, right? So inflamed appendix cause pain in parietal layers of the peritoneum. This signal goes to lumbar one and the patient feels a sharp pain here, which is highly localized in this region, right? But the other nerve, through the sympathetic nervous system, sends the signal to thoracic 1, thoracic 10 level, here. But this pain is visceral, right? Visceral pain is not felt in the origin. It is felt in a remote area in the skin, referred pain. Where it's referred? In an area around the navel, in the armpits, right? So the patient feels both sharp pain here and the dull pain here, right? So here is painful, here is also painful. The pain here is sharp, but the pain here is dull. Dull means weighing, right? So this is an example of dual transmission of visceral pain, or parietal pain and visceral. So now let me talk about temperature, and after that we can have a break. Right? So we have 4 types of receptors for temperature: cold receptors, warm receptors, heat pain, and cold pain. So they are pain receptors, these two, but they involve in feeling of the temperature, right? So cold receptors are collected together in cold spots. So in the skin we have some spots, some points that have collection of cold receptors. We have warmth spots that are collections of warmth receptors, right? So the number of these cold spots is highest in the lips, then in fingers, and very low in the trunk. So the most sensitive part of the skin to the cold is lips, and after that is fingers. But the lowest sensitivity is in the trunk, right? So warmth receptors are also seen. But now let's see the way we may feel different temperatures, right? So here you can see different feelings about temperatures. Maybe we feel cold or cool, or indifferent, or warm or hot, burning hot, freezing cold. So these are ranges of temperature we can feel, right? So how we can feel these? While we have only 4 types of receptors, so it's related to the relative activity of these receptors. Imagine that the skin temperature is at 5 degrees Celsius, right? So at this temperature of the skin, the only type of receptor which is active is cold pain. So this is the number of action potential transmitted through these receptors, right? So cold pain receptors transmit 6 action potentials per second at this temperature. Other receptors, cold, warm, and heat, send 0 action potential, no action potential. So the only type of receptor that is active at degrees 5 degrees Celsius is cold brain receptor, right? So it's highly active. Then imagine that temperature in the skin reaches 6 degrees Celsius, a little more, right? So at 6 degrees Celsius, cold pain receptor is again active, but lower, less, right? Other receptors are still inactive, right? So we feel less cold pain, right? So when we increase temperature and we reach at about 10 degrees Celsius, what happens? Cold pain receptors are only minimally active. So they may send only 2 action potential instead of 6 action potentials. But cold receptors begin to send action potentials. For example, they may send 1 action potential per second. Right? So cold pain receptors send 2 action potentials. Cold receptors send 1 action potential. So this combination for the brain means that the temperature is at around 10. And we feel again freezing cold, but not that much. Right? So when we increase temperature to, for example, 20, what happens? Cold pain receptor is not active. So it doesn't send any action potential anymore. But cold receptors are very active. They may send 6 action potential per second. So when only cold receptors are active, then this may mean a feeling of cold. If they are more active, we feel cool, right? If they are moderately active, but at the same time warmth receptors are also active, we feel indifferent, right? If warmth receptors are maximally active and cold receptors are minimally active, then we feel warm, right? So, based on relative activation of these 4 types of receptors, we may feel cold, cool, warm, hot, right? Or burning, hot. So, again, on these thermal receptors, we have some channels. So the name of channels are there, TRPV1, TRPV2, TRPV3. So they are ion channels. They are open at different temperatures. For example, let's see one of them, okay? TRPA1. Yeah, TRPA1. So you can see that at about 18 degrees Celsius or less, it's active, it's open, right? But TRPM8 at about 25 degrees Celsius, it opens and it remains open if temperature goes down, right? So in this range of temperature, this channel is open, but other channels are closed, right? So based on these ion channels, we may have activation of thermal receptors. So adaptation in these receptors is very high. Remember that pain receptors were non-adaptive, right? But temperature receptors are rapidly adaptive. When you are in a warm room and then you go out in a cold temperature, at first you feel cold strongly, right? Then after 1 minute, you feel indifferent, usually. Why? Because of the adaptation of the receptors. When we have constant stimulation, at first we have high frequency stimulation, right? High frequency action potential. Then we have a decrease in firing rate. So this is adaptation. And this adaptation happens here very fast. The same also happens for warm receptors. If you are in a cold situation, you come into a warm room, right? At first you feel warm, then you feel because of the adaptation. So, cold receptors use A delta fibers and C fibers. Warm receptors only use C fibers. So, when they bring the signal to the spinal cord, again, anterolateral system carries this pain, the thermal sensation, right? Anterolateral system, which is responsible for pain, also carries temperature sensation. So they come to the spinal cord, enter the tractal viscera, so it's part of the spinal cord around the base of the dorsal horn of the spinal cord, tractal viscera. Then they enter lamina 1, 2, and 3, signal to pain. Then from here they go to the opposite side. They travel in the anterolateral system. They go to the reticular areas, ventrobasal complex, VPN, and then they go to somatosensory area of the cortex. And we can feel cold or warm. So let's have a break, 5 minutes. And after that, I will continue with